Please come to the stage.
Good afternoon, everybody. It's such a pleasure to have a galaxy of academic people as panelists, and more importantly, possibly a more academic group sitting across the dais amongst the audience. Now, the purpose of this conference and the CME is to organize issues regarding safety in surgical practice. So there, though had been a large issues regarding chemotherapy and radiation, I would restrict myself more on the surgical side. And believe me, we have almost around 30 panelists also sitting in the audience. And anywhere in between you like to interrupt and you like to raise an issue, you are absolutely welcome. That's the reason I have kept the cases, not many in number, around 3 of them, so that we have more of discussion and more of inputs from the audience. And the key 3 areas that we discuss today is breast, thyroid, and rectal cancer, because these are very common cancers and they do have a lot of controversies throughout, starting from the diagnosis till the management. So we begin with the breast. And the scenario, as it's a real life scenario of a 48 years female who presented with a clinically malignant 7 centimeter lump with a hard palpable single node. An FNA was done, which shows an infiltrating ductal cancer. May I start with Uma? And the basic question, we don't have postgraduates because many of the questions are targeted for postgraduate teaching, is do you need radiology for this patient? How safe is to go ahead with radiology in this sort of patients? Almost clinically obvious, but still would you go ahead for a radiology in these patients?
Ditendra, before I actually talk about imaging of the breast, there was a small point that I would like to take up. You said an FNAC show.
We'll take up the issue later on. Let's start with the radiology.
Yeah. So the question is, do you want mammography on this patient or not? I think it's imperative that a mammogram should be done in these patients, unless, of course, one had a fungating lesion. And the reason for that is your triple diagnosis, the accuracy goes up only if you have a concordant triple assessment. That's the most important point. And the second is in this individual, perhaps you're driven by the idea that this patient may go in for a mastectomy. Why do I need to know about breast cancers elsewhere in the breast? But then the contralateral breast is also very important. And imaging doesn't really stop with just mammograms. In a patient with a fairly locally advanced breast cancer, you would also consider imaging in terms of an ultrasound to the abdomen. You might also consider a bone scan on this patient.
I'm not going into the metastatic. Now, for the audience, how many of you feel that routinely, irrespective of the size of the lesion, you would go for a radiology? Please raise your arms, please. And those who don't want to do, almost none. So the consensus is whatever the size of the lesion is, whatever the presentation is, radiology is a part and parcel of diagnostics of breast cancer. Now, as I said, now I go to Dr. Chintamani. The issue has already been raised by Dr. Uma. Now, is it safe to go ahead with any form of treatment, be it surgery or neoadjuvant therapy based on FNA? And how would you rate FNA as a diagnostic tool on 13 December 2014?
At what time? Sorry. Well, FNA has its limitations and they're known, and there are false negatives. The gold standard is core needle biopsy, and the reasons why we need core needle biopsies are number one, you would get a tissue diagnosis rather than a cytological diagnosis, which is mandatory before you go ahead. Two, you will get to know about the grade of the tumor. Three, you would have very limited number of false negatives. Four, you'll also get to know about the biological nature of the tumor in terms of biomarkers, and overall understanding of the disease will be better. And to plan, like in this case, as very rightly brought out by Uma, we will be putting on patient on triple assessment regardless. I mean, we don't have to even think about whether imaging is needed or not. And triple assessment essentially is clinical examination, imaging, whether you do mammography or ultrasound or both or MRI or whatever. And the rest would be based on core-needle biopsy. So I don't think fine needle aspiration cytology presently has a place in the management of breast cancer. Having said that, we always find that problem in most centers. People would have limited exposure or limited availability of core-needle biopsy. So they are sticking onto FNA. But the trouble with FNA is, as I mentioned, false negatives and some false positives also. So it will have limited role. Personally, I feel, and generally this is the NCCN guideline also, core-needle biopsy is the gold standard.
Anybody who would like to debate it out in favor of FNA within the audience, you could raise your arms. So if there is none, so it's obvious.
There is one.
Is there anybody? Oh yeah, I have Dr. Mukherjee
Dr.
here,
Mukherjee, yes,
who would
sir.
like to debate it out in favor of FNA.
Just logistics, Dr. Chitamani. I'm not actually disagreeing with you, but day-to-day practice, it's very difficult to find out a center where we can get a core-needle biopsy, even in large cities.
Excellent point. I mean, thank you for disagreeing. It's important. The key issue is there are lots of misunderstandings about the availability and the feasibility of core-needle biopsy. It's a simple procedure, and most centers are able to do it. And if your pathologist says, I cannot interpret it based on whatever you've given, then just change your pathologist. But core-needle biopsy is not a very cumbersome procedure. The needles are cheaper now, and at any point of time, if one has to learn it, it doesn't take more than 5 cases to pick up core-needle biopsy. So that option of, we don't have the facility, we don't have the capability, etc., is no longer acceptable. I'm sorry. Although I agree with you, even now, even city of Delhi, why talk about the remote areas or peripheries, people still manage breast cancer based on FNA, but it is not recommended. Thank you.
So I think if there are nobody who disagree to this comment, we go ahead with the next question. And now this patient was adamant on conserving the breast. Now I start with Dr. Gupta. Is it safe to advocate breast conservation therapy for this 48 years lady who has a 7 centimeter lump?
It's not impossible. The only absolute contraindication for breast conservation therapy in this woman would be multicentric disease. But if the mammography shows only a localized disease, even if the patient has got a deep tumor, and if she's still keen on close follow-up, I would give the option. There's 20% chance of local recurrence, but if she's happy with that, that's possible.
Okay. Dr. Uma?
I think in a postmenopausal lady, the survival with breast conservation is probably greater than with a mastectomy. Those are the numbers that are coming out now. So I think we as surgeons should have offered her breast conservation. And please correct me if I'm wrong. I saw that to be an outer quadrant lesion in a fairly large breast. So the size of the lesion being 7 centimeters is neither here nor there. I think this patient would make an excellent candidate for breast conservation. And you've already said that she had a palpable node. And if that had been either core needled or FNA'd and found to be metastatic, then one can combine axillary dissection with it quite comfortably, perhaps with a separate incision.
Dr. Chintamani.
Well, I agree with both of them, and at the same time, see, always is always wrong, especially in cancer, and never is never right. So we would never have an answer. Cannot be done, can never be done. And like Arnab said, it's possible. And I assume that this patient would receive neoadjuvant chemotherapy, which would downsize and downstage it to an acceptable level. And if she's a good responder, why not? And as rightly mentioned, postmenopausal women are supposed to do better, they're known to do better. The other issues that you need to address would include the issue that Dr. Mukherjee raised with the previous question, whether the patient is able to travel to the place of radiotherapy, because that's a big issue, whether she actually wants it. But it's very important that very often we make a decision on behalf of the patient, well, you must have breast conservation because that is what is good for you. There many a times the patient would ask you questions, like you mentioned about 20% recurrence rates. So when you offer it to the patient, you must mention that 20% or perhaps higher recurrence rates. Are you accepting them, although the survival won't change, and we'll manage them locally again, it's not a big deal. But the patient doesn't want a ticking time bomb inside, so she would say, mastectomy, thank you very much. In that case, the decision would be left to the patient. It is possible, it is feasible, and it is recommended. If 7 centimeters is very borderline, you can bring it down to 3 to 4 centimeters. With a good tumor breast ratio here, breast conservation should be offered if the patient wants it. And after you explain.
Okay, how many of you in the audience would actually go ahead, depending on your scenario, a neoadjuvant chemotherapy, downsize it and go for a breast conservation? Please raise your hands. So we have a large group of delegates who agree to for breast conservation, and how many of you disagree actually? Or none of you disagree. So it's a consensus that
it's a sample size problem. The numbers are less.
Now, I understand, as you already said, that you need neoadjuvant chemotherapies. And the issue again, when it comes to an Indian subcontinent, what would be a cost-effective way of giving a neoadjuvant chemotherapy? What would be your recommendation? Anybody of you can take. What particular chemotherapeutic agent will you choose? I mean, bluntly, you will go for a taxane, or you still continue with FAC?
I think the traditional first-line chemotherapy agents are more than adequate because within a matter of about, say, a couple of doses, you will start seeing the impact. And there is really no reason to go in for a second-line chemotherapy for downsizing, particularly if this patient happened to be ER, PGR positive, then I think first-line, traditional chemotherapy is more than adequate.
So anthracycline-based chemotherapy regimes would be fair enough. That's your choice.
Yeah.
So how many would you just go ahead and use taxane as a more safer chemotherapy agent to achieve downstaging in a better way?
Then it's a question of availability. Sorry.
Yeah, Subro would go for taxane to begin.
Yeah, if you got taxane, that it's known to have a better outcome. You know that we get higher PCR rates, but as very rightly pointed, put by Dr. Uma, adriamycin-based or basic first-line chemotherapy is good enough, and in a couple of cycles, you would know the patient is going to be a responder or not.
Okay. Now,
I just want to add that taxane is not always considered as a second-line therapy. It can be used as a first-line therapy as well. So, like Shubro said, it can be used as a first-line as well if the patient can afford. But anthracycline is good enough for most of the cases. So you can try with 2-3 cycles of anthracycline and reassess.
Particularly if you have higher grade tumors and TNPCs, you can straightway go for taxane. Otherwise, it's safe to go for anthracycline. Now, I have this question for this lady who is kindly consented to be part of the panel, Ms. Orpita Mandal. Now, I have heard about these things and you have actually worked on that. What would be the role of a nurse navigator in such situation, guiding the patient to a safe outcome?
Okay, as Dr. Chintamani has said correctly, that most of the time the doctors take actually the decision for the patient in Indian situation. But nurse navigators actually become a good friend and mentor for the patients from the beginning of the diagnosis through the end of life care. The nurse navigators actually guide them through their options of treatments, give their care coordinations that is mostly valuable for them, whether they are going to be information to them like in correct time. The treatment options also usually they discuss with the patient, so it's become easier for the patient to take the decision not from the behalf of the patient, the doctors taking the decision. Here comes the nurse navigator in this kind of situation, and they take good decision for the patient.
I just raise a small issue. How frequently you did find that your counseling had actually make the patient decide the course? Because it's quite different in the West, where the lady would actually go through volumes of literature and come to the OPD, and he has already taken some sort of decision, and you can just modify it. In India, I think at the end of the day, if you give multiple options, they tend to get more confused, look at the doctor as if he or she is a god. That's by and large the majority
Yes.
opinion. And
Yes.
then they would come up, want a verdict from you. How would you put that in decision making?
Well, still, it's the patient choice once again. We have to describe as much as possible to the patient about the options. Now, it's to the patient's opinion only. As you described for this lady, the patient wanted to have a, breast conservative surgery. So, in that case, I would rather prefer the patient having, all the decision in front of her, and she must be taking the decisions.
Okay. Now I have a question for the audience. Now I firmly believe that we are all human beings, and when we do counsel a patient, we tend to have a biasness amongst ourselves. How many of you would rate that the surgeon or the nurse navigator is to certain extent biased when he puts the option in front of the patient? How many of you feel that we are actually biased and we would like to hear the yes that we want to do on this patient?
Yesterday I saw a patient in the hospital. Even the husband didn't know she had a huge breast cancer. And she comes from one village. Will she be benefited with her counseling?
That's an issue. How many of you feel that we are absolutely unbiased when we are offering a form of treatment? I am strictly speaking on Indian perspective.
Yes, that's what I'm saying. She comes from one of the villages and she's, I would say uneducated, but nearly there.
Even educated seems to be quite uneducated in most of the circumstances.
Depend, it's very subjective, I'm sorry. Actually, it will matter. It depends where you are and what situation, the kind of patient you're dealing with. Because very often, as you rightly said, they would like to piggyback on you. They would expect you to tell them what is the best option they have. And while trying to deliver this part of the story, you may be a little biased because that's where this can happen. All the decision making, if you have a patient who is smart enough to understand what you're saying, and if you tell stories of both the sides, it's often possible to be less biased than you normally are. And as you rightly said, as human beings, we have our choices and we do have our preferences, although we work at them. But at the end of the day, it depends on the patient, the tumor in the center, and the surgeon. It totally depends actually. So it will vary, including what the nurse navigator has to say. Very often the patient leaves it to you completely because if very common question is, if I knew all about it, why would I come to you? To that you start explaining, even I don't know all about it. So she starts having a second thought. So let's go to somebody who knows all about it. So it will depend. It will be very subjective.
Now, this was as the patient has gradually gone through the neoadjuvant chemotherapy. This was actually in serial mammograms and serial MRIs. If you put the patient as the patient goes down in neoadjuvant chemotherapy. Now, I would like to know there are two perspectives. One is downsizing of the lesion. So, what would be your best way of monitoring the downsizing? At the same time, as we will come later on, we will see that some of the lesions do not have a predictable pattern of shrinkage. Rather, it's a Brownian sort of shrinkage they have. And of the 5 things that you have here, first I will ask those of you feel that clinical is the best way of assessing the downstaging. Please raise your arms. So none of them feels. In favor of ultrasound? 1, 2. In favor of mammogram? We have 4. In favor of MRI? We have 3. And PET CT? PET CT? None. So as it thinks it's statistically insignificant, but it seems that it's divided between mammogram and MRI. Your take on that? There are two issues actually, shrinkage and the pattern of shrinkage.
Okay. Patterns of shrinkage don't really have to concern us. What we really need to focus on is, am I going to get a clear margin in this patient or not? Now, fundamentally, I think it is the hand that decides whether this patient can take a breast conservation surgery or not. It is, I tend to avoid imaging, I confess it. I would rather go by my clinical judgment. But I take your point that sometimes the shrinkage of the tumor is not in the manner that you want. And in such cases, an ultrasound, which is a relatively inexpensive investigation, is quite all right. The thing that will bother me is if the lesion completely disappears.
I will come to that as well.
Yeah.
Dr. Chintamani,
We've used all actually, and we published our data separately in each group. I think clinical and ultrasound is what we found ultimately is ultrasound is an extension of clinical examination. It's actually the stethoscope of a surgeon now. So ultrasound should be taken away from the clinical examination, and an actual good clinical examination in breast is now clinical plus ultrasound, where you do the clinical examination of the breast as well as the axilla and ultrasound of the axilla and breast. You know that. Now, so the two in the beginning are the best, and the last is actually the last. PET CT is the most confusing investigation that you can come across. It'll just show up, especially in this part of the world, some little node in the mediastinum, which is tubercular actually. It'll pick up the activity, or some vague node in the mesentery. Tuberculosis being so common, and it'll confuse you thoroughly. End of the day, you won't know whether it's going to work or not. Although there is a PET racist criteria now, where they look at the activity, because like Dr. Uma was mentioning, the tumor may disappear and so may the patient. But the problem is, whether the tumor is actually gone, you would know. The activity is what you need to assess. And for that, PET can be a useful tool, but it doesn't work very well as an assessment criteria. So I personally think clinical and ultrasound, MRI and mammography. The problem with mammography is, that if I may touch it, is that the clinical, there is a distortion of the architecture after chemotherapy, and mammography can be confusing. So it won't give it is not a very sensitive investigation in post-chemo kind of patients. So clinical and ultrasound. Ultrasound is a poor man's MRI, MRI is a rich man's ultrasound. So MRI can show you something better, and in actual RACIS criteria, when they got down to single dimensional measurement, they had recommended MRI, but they've got back to ultrasound now. So as rightly pointed out, your hands would feel it, and ultrasound would be an extended hand to know whether what you felt was right.
out of the quick take, just which one?
Clinical examination, and then if you're planning for a breast conservation therapy, you should get a mammography done.
Okay.
PET-CT should not be in this list after neoadjuvant.
Okay. So by and large, the consensus is the last one is out. PET-CT should not be used. You can choose between clinical and ultrasound. That's the best, possibly the most workable one. You can just chip in with mammograms occasionally if you want to do that. But by and large, it's clinical and ultrasound. Though the audience feels MRI and mammogram, the panelists feel clinical and ultrasound, but it's statistically insignificant. Next, we go to the next one. Now, this patient, as we were rightly addressing the issue, had a shrinkage to 1 centimeter, and that was obvious in radiology. The question is, what is the safe time to operate? After 3 cycles, or you exhaust all 6 cycles? Which is the safest time to operate? 3 cycles versus 6 cycles?
Well, now most centers like to do all the 6 so that you have the best. See, if you have to choose between systemic management and local management, the trouble with LABC, which is this case, is that there is more of a systemic problem. There is a local problem also, but more of a systemic problem. So you should finish off with your systemic therapy, then get down to the local. Although we do 3 cycles, then surgery, and 3 cycles after that for different reasons. One being, you can assess the response to neoadjuvant chemotherapy and actually have an in vivo chemosensitivity test. If the chemotherapy is doing well, the PCR rates can be assessed. So this intermediate endpoint helps you achieve that. And the other trouble is the performance status starts dropping. Sometimes it's with 4 or 5 cycles, the patient may not be fit enough for even a haircut, so you can't be going for surgery, even though you got the tumor responding. So it's optional, but the recommendation is if the patient is doing well with chemotherapy, might as well finish with all 6. so that you achieve the best systemic response and then you can hit for the local one.
Quickly, Dr. Uma, 3 versus 6, just a quick word.
I agree completely with Dr. Chintamani. The patient is doing well and can take 6 cycles. Logistically, that
6.
seems very reasonable, but otherwise, 3 cycles.
Out of the 3 or 6?
The problem with completing 6 cycles of chemotherapy, one, you can have a complete disappearance of the tumor, and secondly, after 3-4 cycles, there are cases.
So we
where
come
you
to
can-
the next
where you can
question,
actually have
as you see
resistance.
here. Now, to ensure a safe index zone excision in this case, when you have a complete remission, what are you going to do so that when you excise the lesion, which has clinico-radiologically disappeared, what are you going to do?
The other advantage, sorry, can I answer that?
Yeah, surely.
When we were doing core needle biopsy, simultaneously, the other advantage of doing it, I mean, we are doing that as a routine, just get the trocar out and through the sheath, you can push in a small little piece of metal in the core of the tumor, so that you at least know where the tumor actually existed originally, and or a clip or whatever you have, but we use that little wire, it's cheaper and patients can afford, we can afford it, so it's cheaper. Subsequent to the cycles, if the tumor has disappeared, this will represent where the center was, and then you take a safe margin of 2 centimeters around it. That's one way of approaching it. All fibrotic tissue would feel like tumor, but you'll have to go by your gut feeling, and you need to have the frozen section in that case to be very, very sure.
Now, the big issue, the big question, what is a safe surgical margin?
What is the safe surgical margin?
What? Yeah, what is a safe surgical margin?
1.5 to 2 centimeters.
I think my finger, your finger breadth clearance all around the tumor is more than adequate. There is a tremendous amount of controversy going on, raging about the involvement of inked margins. Unless there is a clear breach of the inked margins with infiltrating tumor or very extensive DCIS, I don't think we need to worry too much about distances. I think your own finger breadth is more than adequate.
Now, my question to the audience is, now if you
So,
are...
then can I chip in there?
Yeah, surely.
We do routinely these patients specimen mammography, specimen X-ray, which actually would take care of the DCIS or the microcalcification that you can see. And in fact, we have found that compared to frozen, it's a better way to do it because you get a structural histology, I mean the structural view of the whole thing. Frozen would at best be 4 corners, and breast doesn't, the fat doesn't freeze very well, so frozen can have that problem. So we do an X-ray of the specimen. So that also helps us know whether the margin. But I agree with her completely. It's very controversial. As long as you're a couple of cells away from the last cancer cell, you're fine. But how do you see that is the issue. Yes.
The question to the audience is that how many of you would actually not go ahead with the revision excision of the cavity wall, even if you find the margin to be marginally positive? That means it's focally positive. How many of you would actually call back the patient for go for a cavity excision, and how many of you would straightway send the patient for further adjuvant therapy? Those in favor of re-excision for a positive margin. Okay, so around 3 or 4 of them. How many of you would actually send the patient for radiation? 2, 3. So it's 3-3. Well, what would be the consensus? As Dr. Uma rightly said, if you have a focal positivity at a particular point, there is no reason to go back and do a re-excision. But if it's a diffuse positivity, gross extratumoral DCIS, these are candidates to go for a cavity shaving or even counseling in favor of mastectomy in certain situations. Now, this is the tumor, and this has shrunken down to this. What is the final margin, the original one or the shrunken one? When you assess a margin, the original one or the shrunken one? This is the original one, and this is the shrunken one.
The problem is, it's not usually the shrunken size which is important. There will be some settling around. So, 1 centimeter margin, which is normally recommended for a primary tumor, may not be adequate in this sort of cases. So, 2 centimeter margin is all you should be aiming for this kind of tumor.
But
They
you
might
are
be-
based at the original volume
not
or
original
the shrunken volume?
shrunken margin. Otherwise, there's no point doing neoadjuvant chemotherapy.
So you are based on the shrunken volume.
Otherwise, why would you be bothering to shrink it down?
Exactly.
The whole issue, the advantage that you're looking at is to get the margin and get it smaller. That's it.
So the measures that you take to get a safe R0 status, you have these three options: postoperative histopathology and decide, a frozen section and decide, a frozen plus a post-op histopathology. What's your choice? Let's begin with that. Now we will take this issue with Dr. Sunil Kumar and Dr. As well, because they are GI surgeons.
No, it's all
so
right, yeah.
but they can actually. Can you decide based on only frozen or frozen plus histopathology
We don't do
or
much
HPO?
breast. We don't do much breast. But I would have thought the frozen section generally has certain issue. We have frozen section in our institution. We sometimes do send it. But the best would be a post-operative histopathology and decide. That's what I would go for.
I think as breast surgeons, we would go in for frozen section and always follow up with post-op histopathology, because it's not always easy for, as you rightly pointed out, to submit an entire shaved margin and to a pathologist and expect him or her to come up with 100% accurate answer.
Okay.
We will do frozen, the pin, and specimen X-ray, and later on rely on the final histology we rightly put, because frozen has its problems because the fat does not freeze, so you may miss it. The X-ray is very useful. That radiology of the specimen is very useful too.
Okay. One final question from the breast is: there is complete clinical radiological remission. Is it safe to omit surgery for these patients?
Absolutely unsafe. It's blunder. It will be considered a poor management of the patient. Although that's what I was saying initially, the tumor disappears and the patient also disappears. I have no tumor now. You must make sure that these patients keep coming back, and it's a horrible cancer that they get when it comes back. They come back with a recurrence which is unmanageable. It should be treated by surgery. We have to get the tumor, they get the treatment, surgical treatment is mandatory, and then adjuvant therapy is also necessary. The neoadjuvant chemotherapy, tumor disappears, treatment follows as it is.
Okay. Now we go to something on thyroid cancer. Now this was a lady with a 2 centimeter size lesion, and FNA was papillary carcinoma. It's an unifocal complex lesion seen on ultrasound. The first question is it safe only to perform a hemithyroidectomy? Now how many of you would actually, for a small unifocal lesion, go for a hemithyroidectomy as a definitive procedure? None. In favor of total thyroidectomy?
Yes.
All. So the consensus is very strict. No hemithyroidectomies. Yeah.
The fact that you put a question, you must be having some doubts. And there are doubts, because nowadays there is a serious recommendation from American Thyroid Association and European Thyroid Association that you must stratify your patients and tumors very, very carefully. A high risk tumor, high risk patient, total thyroidectomy. High risk tumor, low risk patient, total thyroidectomy. Low risk patient, low risk tumor, hemithyroidectomy is permitted. Because when you talk about total thyroidectomy in papillary cancer, it's based on three basic reasons. One is that it's a multicentric disease, and you may get microfoci on the other side, what is called as a laboratory cancer. And the third thing is you have a very good cancer which is going to do very well, and you don't talk in terms of 5 years survival, you talk in terms of 20 years survival. So might as well do the maximum, to the extent that people do prophylactic central neck dissection in these patients. So this is how you got to stratify. So this lady is 35-year-old, falls in a good risk criteria group. Tumor is small, good risk. The description was good. I hope the grade was good too. So then you can actually offer hemithyroidectomy. It also depends on the center, the surgeon, the patient, and everything, because there is a method of assessing which center should be actually doing total thyroidectomies in the first place. Because the complications associated with total thyroidectomy wouldn't justify the kind of cancer that the patient is carrying, because with this disease she can live for 20 years comfortably. It is possible. Therefore, there is a reason. And if you're not stratifying patients, then the best answer is total thyroidectomy.
Just briefly, what are the actual issues on which a nurse navigator is going to counsel a patient who is having a thyroid cancer? Just very briefly, because we are running short of time.
Okay, the first one is definitely living chances that the patient may face that she has to explain to the patient. Another thing is the hoarseness of the voice, which is probably most common complications of the thyroidectomy. So these two things they have to explain very extensively to the patient that there may be chances of these two, and especially the hoarseness of voice because it's a voice is by and large anybody's
Okay.
common complication.
Now, what are the common sites? Because when people are doing a total thyroidectomy, many of them tend to do a very safe thyroidectomy. What are the common sites that you have encountered where there is leftover of thyroid tissue? Where exactly the surgeons tend to be over safe?
Three places. Superior pole, that old dictum, tie it close to the pole or tie the pole with it. That is no longer acceptable. We got to create that space of reefs medially, do a medial dissection, isolate the artery, nerve, and vein separately, look for it. I mean, I'll add to what the nurse navigator was mentioning. It's not just the hoarseness of voice, which is one issue with recurrent laryngeal nerve. The external laryngeal nerve is a very important issue, especially in singers, teachers, preachers, and most importantly, the politicians who have to shout at the top of their voice. Because the timbre and pitch of the voice disappears, and they otherwise have a normal voice when they're speaking to you in a softer tone. So it's very important to counsel the patient that this can happen. It could be transient, may disappear, but you may recover. Now the second place is close to ligament of Berry, which is where the nerve is entering into its place. People tend to leave some tissue there. It's not a bad idea to leave it if you are having a trouble locating the parathyroids. And the third place is the inferior pole, where when they're ligating, they don't go down and dissect the thyroidothalamic ligament. If you dissect it, then you will be able to find it out. The other thing which is important is inferior thyroid artery. Sometimes people end up ligating. The earlier dictum was ligate close to the superior pole, away from the inferior thyroid artery, away. Now, inferior thyroid artery is not ligated. We just ligate the capsular branches as close to the capsule as possible, and that's where you can also leave some tissue. So these are the 3 or 4 places where most of the tissue is left.
Now, what are the guidelines for the superior, the external laryngeal nerve? How do you identify and what are the landmarks to do a safe thyroidectomy in the upper pole?
Well, as I said, like you've shown all the 3 types here, we need to do the medial dissection by following what is called the Nihas maneuver. To pull the lobe up, open the lobe down and out, so it opens up that space. And medially, you got to dissect, isolate the artery and vein. If you ligate the artery and vein like it used to happen in the good old days, where you just ligate the whole trunk, the whole thing, the whole thing at the pedicle, you end up forming AV fistula. It does happen, mind you. So it's important to isolate each structure, and as you do so, you would be saving the nerve automatically. And if you do not see this nerve, you must look for it. So the old dictum, not seen is damaged, not seen is safe. No, not seen is damaged. So you must see and demonstrate. So it is important to do what is called a medial dissection at the superior pole by pulling the lobe down and out. So that opens up that space and you can actually dissect it. It's visible in about 70 to 80% cases, their own publication. Earlier was 30%. People felt that externally you would rarely see, but it can be seen if you look for it.
How many of you actually would visualize the recurrent laryngeal nerve when you are going for total thyroidectomy? All of you. And how many of you would not like to demonstrate that? None. So the conscience is very straight, but just what are the guidelines for locating the recurrent laryngeal nerve if you try to visualize that? Obviously, we're going to try that, but what are the basic guidelines? Now you have the whole thing in front of you. Where exactly would you like to locate it? At the thoracic inlet, or you would like to go it at the groove?
Depends which side you are. Actually, if you're on the right side, it comes at an angle. So I don't like this diagram because the right side should be at an angle and you're likely to damage it if you're not careful. And looking at its entry into the neck is one way of doing it, especially when I'm doing it for cancer. I'm doing central neck dissection, so I'll start from there. But generally speaking, it is better to stick to the orange peel dissection, which we followed, starting with the superior pole and getting into the capsule. It appears on its own. And many a times, if you chase it, you may not find it. Are you done with it?
Yeah, no, you can go ahead.
Sure. Thyroid ligament, as you rightly mentioned, you can have the fifth parathyroid gland. 5% individuals may have 5 parathyroids, generally we have 4. So it's important to locate it as it is entering into the ligament of Berry and then trace it downwards. Or you can start from the, the point where it's entering into the neck and trace it up. The important issue is not just to see the nerve. There is a vessel that goes with it, which is often ignored. And the damage to the nerve is ischemic. You may find it's anatomically intact, but functionally the patient has a hoarseness. So it's important to preserve it, and no longer is it recommended to bear it unless you're doing a surgery for cancer, as I mentioned. Because you try to bear it, you're likely to cause the ischemic damage. So therefore, these are the two places. And what is recommended is you should look for the point where inferior thyroid artery is crossing the nerve. So that's a very common place you'll generally find it. Usually.
This is the capsular dissection and how you
Yes.
do it.
That's right.
So now this patient has a Massey score of 3.9, which is an extremely low risk, and the radioiodine uptake was 1.2%, 1.02%. Would you advocate ablation? Because most of the nuclear physicians would generally advocate, by and large, ablation in all patients. Now, would you all of you recommend that, or no? Would you advocate ablation in all patients?
In our center, yes.
All patients. Even if one cell is left, you are going to ablate.
That's a recommendation in our hospital.
Okay. What would be the recommendation for resurgery? When would you go for the resurgery? I mean, large percentage of gland, you say more than 10%, would you recommend the resurgery?
If it's a large residual, yes, but not otherwise. If it's a small residual, we go for ablation.
It's actually, there's a recommendation, more than 20% or 15%. I mean, you've done a disastrous job, like you left behind everything. And it's bilaterally you're left behind. Then no point going in for surgery again because you'll cause more damage than you'll achieve. The benefit is limited. They are candidates for radioactive iodine ablation. Our nuclear medicine people are very happy to ablate the complete lobe, but that's a very high dose, shouldn't be done. With this uptake and a massive score of 3.9, it's not a bad scenario. But most of the places, most patients, it's advisable to give radioactive iodine. It's very safe, and actually you can achieve what is called, there's no R0 resection in thyroid. It's based on the uptake, and this is not R0, so you can achieve R0.
Okay. We go to
Just from my knowledge, but the standard teaching has been that it has been less than 3%, possibly that there is no need. But are you saying that it has changed now? As Arnav is saying that every patient of total thyroid,
Yeah,
maybe it's less than.
actually, if you look at the nuclear physicians, we also used to mention those days that less than 2% you are safe, you can leave behind. But now, if you send a patient to nuclear physician, they don't believe a single surgeon.
Sunil has a point.
There is no randomized control
Yes.
trial in favor of radioiodine ablation prolonging life. But it's the wrong.
Actually, there is no randomized control trial in thyroid for that matter.
No randomized.
So you can say whatever and you may be right. The problem is, if it is bilateral, even with this percentage you would need it. Otherwise, I agree with him. Less than 3%, you can actually leave it alone. This is a cancer that's going to do well regardless. But if you have an option, it's a safe way to go ahead and you can get rid of the last cancer cell. That's what they say.
Okay. Now, surely.
We are not that short of time. Can we have just 1 minute discussion, consensus amongst yourselves about NPC?
Surely.
An NPC. An incidental ultrasound showing a less than 10 millimeter thyroid nodule. You do an ultrasound guided FNA and it's papillary carcinoma, micropapillary carcinoma. Can we have a 1 minute discussion?
Micropapillary carcinoma, would you go for?
See, the problem, I've understood incidentaloma, which has come out to be microcarcinoma, and it's a big controversial area. The problem is now the patient knows it. If you don't know about it, it may never become a macro. That's one issue why he's asking this. If it doesn't, then this is an overkill. So it depends to a great degree on whether the patient received some kind of a radiation in the past, which will make him a high risk or make her a high risk case, to whether, it's mentioned, but I don't know whether that will work out. If the patient wants it, you have no choice. And thirdly, for those who would like to observe If the patient can come for a regular follow-up, a micro can be actually observed. They may not change into the true cancers ever. But the trouble is you have a patient who's carrying a ticking time bomb inside. At least she feels so. It's usually a she, that's what I'm saying.
It's like a BRCA gene.
Yes,
Big positive.
do something.
And
Do
then you have to
something.
do something.
I have it. It's now just one little increase in size. What do I do for it? So actually it depends on the scenario. But logically speaking, it may never become macro. So there are many microcarcinomas that people live and die with.
Anything more? Now we go to the last scenario. We have two GI surgeons, but we have actually kept them completely silent. And I was forced to do that. They do not do breast and thyroid. Now we have this scenario of a 52 years male presenting with recurrent rectal bleed. The digital rectal examination showed a lesion which is situated 4 centimeters from the anal verge. Colonoscopy is a unifocal middle lower rectum carcinoma. HP is poorly differentiated adenocarcinoma. Now the issue is whether you will consider rectal preservation in this patient. Dr. Sunil Kumar, please.
Once you have done all the staging and performance status, 4 centimeter is too low, means it's right near the sphincter.
It's a borderline zone actually.
Yeah, it's right about the and see, if you look at the evidence, if you look at the things, he can be offered. But what I would do, 4 centimeter, 52-year-old man, because the recurrence in rectum is almost a death sentence. It's not like a recurrence in breast or anywhere else. So possibly I will go for or advise for an API in this patient than to venture for a sphincter preservation. That would be my approach.
Your take, I mean,
You're going to get silence from me because I'm an upper GI surgeon. This patient I will refer to my colorectal colleagues, so I'm not going to argue with Steve Kumar.
That's safety inside.
that's safety inside.
Safety fall, yes.
Raj, what did you do? Are you going to go for an LAR? I mean, there are newer things that have come out. Evidence is 1 centimeter is safe.
I would personally, if it's a well-differentiated tumor,
Yeah.
adequate preoperative radiation, I would still try to do, and I would try, I still do all the time, ultra-low anterior resection, get a cold way to pull through and anastomosis at the dentate line, which will give us about 1 to 1.5 centimeter. But I take his point that should there be poorly differentiated tumor, any problem, I would convert to an APR. I would keep an APR, no pressure of APR, and I would still try ultra-low anterior.
Look, Dipen, if it is down at positive, then you may convert it. Although even that's a lot of centers like to treat with radiotherapy, etc. But if you can actually shrink it further, you can achieve it. An attempt can be made, but then you get a clear margin. That's what we're looking at. And after you've cleared it from all around, it sometimes becomes longer than you feel. I mean, you may get a better margin than you're looking at. But a safe bet with a poorly differentiated old gentleman, it would be 50-50. Unless he's fussy about it, don't make him fussy about it.
Okay. Now, again,
Yeah, I'm pretty conservative because I think what would I like done if this was in my rectum, and I think I'd rather have an APR rather than,
Sanjay, then?
So the horrifying thing is to have a distal donor positive. What do you do then?
Yeah.
APR.
APR. So that's a borderline zone. Newer recommendations and evidences are coming that 1 centimeter is fair
1
enough.
centimeter is fine. Later on, it will come down to, like I said, 1 cell away from the last cell. So you never know. And then they say margin doesn't matter. It's happening actually.
Yeah.
And they are talking about the donut positive versus donut negative. The American College of Surgeons meeting, I was attending that debate. And they are happy with donut positive also, which is scary. So it is better to recommend APR in such a scenario. The take home should be that.
Okay, in case you are planning an LAR, how many of you are safe with a primary anastomosis without a diversion?
We are safe. About the patient, the problem is. So you need some kind of a diversion most of the time, right?
Yeah, Arnav, that. Would you go for a diversion routinely?
Is it You're talking about the same patient or a different patient?
Yeah, maybe an LAR. Forget about the centimeters. Maybe 5 or 6
If it's
centimeters.
upper rectum, it's not always required if you're happy with the anastomosis. Mid and lower rectum.
How are you happy with an anastomosis? I mean,
We'll check the tension, whether it's tension free. It should be vascular. It should be leak proof. So you can check with water.
and possibly a sixth sense to a certain extent. Yeah, that's it. So, how many of you are more or less safe while doing an LAR? I mean, the anastomosis, or routinely go for a diversion?
The radiated data saying that subset that has a maximum leak is
Post-RT, yeah.
no tumors would have radiation. This kind of guy, I would radiate him, and if I do ULAR, the donor negative, I would 100% do a covering ileostomy, loop ileostomy.
Okay.
It is safe. I mean, whenever in doubt, take it out. I mean, that's the dictum. And you should be using that sixth sense. I mean, I'm sorry, I disagree with you, because that's where the trouble comes with that, especially in this case, gut feeling. You can actually roger this gut unnecessarily. When you've done an LAR, and ileostomy is a very innocuous procedure, and you can close it within 4 to 6 weeks.
Again, my residents have asked me quite frequently, colostomy or ileostomy?
Ileostomy is easier to do, easier to reverse, easier to manage, especially terminal 1. Colostomy,
Arnab has something to tell.
The only issue with ileostomy with our set of patients, many of them are poor. They'll go for whatever stomach bag you provide them. They will go back and use the plastic bags wherever they get from. And once you have a very ileostomy, excoriation is a big problem. So if I get a poor patient, I'll do a colostomy. Otherwise, ileostomy, yes.
Speaking from my colorectal colleagues, I think, from my clinic, we do a lot of loop ileostomies.
Okay.
Basically, the dictum is in ultra low anastomosis and a difficult low anastomosis always defunction. But if it is not difficult upper one, possibly then you can think and take a decision, selective. But ultra low difficult, it's better to do always a defunction.
We have this question, what are the safe landmarks for doing a safe TME? How to decide? I have Manojda here sitting behind. A safe TME. Yeah, please. What are the guidelines for TME, landmarks? This is an adequate lateral clearance.
Basically, you follow the avascular presacral plane, and laterally you should be on the two sides. Anteriorly, you should go behind the seminal vesicles, and you could see the lovely levators coming all the way. Okay. And you should protect the presacral nerves, the ureter, all those things.
So I think we are running short of time. Let's go to the conclusion. Thank you very much. It was indeed a pleasure to have this august panelists and the delegates. Thank you very much indeed.